Okay, so let's start. Okay, so let's start with the parasympathetic nervous system. Mm, I will share a screen with you. So, okay. So when we are discussing when we discuss the impact of autonomic nervous system on the heart muscle, we need to remember that sympathetic nervous system innervates the conduction system of the heart and cardiomyocytes of atria and ventricles. Uh, Parasympathetic nervous system, on the other hand, innervates conduction system of the heart, including semi-atrial node and atrioventricular node, it also innervates the cardiomyocytes of the atria. There is no parasympathetic nervous system innervation of the ventricles. That's why parasympathetic nervous system has no direct effect on contraction force of the ventricles. So there is no direct, once again, there is no direct effect of parasympathetic nervous system on contraction force of the ventricles. However, it is possible for the parasympathetic nervous system to influence contraction force by the regulation of atria cardiomyocytes contraction force. So there is indirect method of regulation of the contractility. Contrary to the sympathetic nervous system and the beta 1 receptor, M2 receptor is associated with GI protein. GI protein. So it is M2, so muscarinic 2 receptor, which is bound to GI protein. So the GI protein typically, as we discussed last time, consists of alpha, beta, and gamma subunit. The alpha subunit is connected with GDP molecule. Acetylcholine binding to M2 receptor leads to GDP replacement by GTP molecule. Okay, and because of that, the alpha subunit dissociates from beta and gamma subunits. The beta and gamma subunits stay connected with the cell membrane, whereas the alpha and GTP subunit translocate to the cytosol. And now alpha GTP subunit of GI protein decreases the activity of adenylate cyclase. Therefore, the concentration of cyclic AMP decreases as well. Because the concentration of cyclic AMP is decreased, the activity of protein kinase A is decreased as well. And what's the impact of decreased cyclic AMP concentration and protein K activity in pacemaker cells? In pacemaker cells, decreased concentration of cyclic AMP reduces the sodium current through the funnel channels. Lack of T and L channels phosphorylation by protein kinase A also decreases the calcium current, mainly through the T-type calcium channels. Okay. Additionally, or more important, beta and gamma subunit of GI proteins, which are bound to the cell membrane, maybe not translocate, but they move along the cell membrane, and they bind to, sorry, this is not what I hoped. One more time. I will quickly draw this graph one more time. Okay, so beta and gamma subunit move along the cell membrane, and they bind to Girk potassium channels. Okay, because of that, the channel protein opens, and a rapid and excessive outflux of potassium ions is observed through the cell membrane. So potassium ions diffuse through the cell membrane through the Girk channels, which are activated by beta and gamma subunits of the GI protein. Because of this very strong potassium outflux from the cell, as well as reduced sodium current through the Fano channels and calcium current through the T-type calcium channels, the slow depolarization of the pacemaker cell membrane is prolonged. Therefore, the whole duration of action potential is prolonged. That's why the frequency of action potential generation by the pacemaker cells is reduced, which reduces the heart rate. In case of cardiomyocytes, the situation is opposite to the situation observed in a case of sympathetic nervous system. So because the activity of, after binding of acetylcholine to M2 receptor, the concentration of cyclic AMP decreases. Therefore, the activity of protein kinase A decreases as well. That's why dephosphorylation of L-type calcium channels and ryanodine receptors, as well as troponin C subunit is decreased, which has an impact on the intracellular calcium concentration. The concentration of calcium ions inside the cell is decreased after acetylcholine binding to the receptor, and that's why the contraction force of cardiomyocytes is reduced. So the parasympathetic nervous system exerts inotropic negative effect, but this inotropic negative effect is only characteristic for the cardiomyocytes of the atria, because there are no M2 receptors within the cell membrane of cardiomyocytes in ventricles. The parasympathetic nervous system cannot exert the direct inotropic effect in ventricles. What else? The decreased activity of protein kinase A means decreased phosphorylation of phospholamban and calcium sodium exchanger and calcium ATPase in the cell membrane of cardiomyocytes. Therefore, the parasympathetic nervous system induces lusitropic negative effect in the cardiomyocytes of atria. no effect on the relaxation duration in ventricles. Is everything clear? So far so good, or do I need to explain something one more time? Okay, so I assume that everything is clear. And now let's concentrate on the cardiac cycle. Okay, so because of the contractility of the cardiomyocytes, the heart exerts a contraction relaxation activity. Because of this activity, the heart works as a pump. The cardiac cycle, which results from the contraction relaxation or the systolic and diastolic activity of the heart, describes the changes of blood volume and blood pressure in the heart. The cardiac cycle basically consists of two phases: diastole and systole. Within diastole, there is ventricle filling, and isovolumetric relaxation of the ventricles. Isovolumetric relaxation of the ventricles. As well, the atria contraction or the atria systole is a part of diastole phase. The systole consists of two subphases. The first one is called isovolumetric contraction. Isovolumetric contraction. And the second subphase of the systole is called ventricle ejection. So one more time, the diastole consists of three subphases: ventricle filling, atrium, systole, and isovolumetric relaxation. Maybe we should start with the isovolumetric relaxation, which is actually the first phase of diastole. So isovolumetric relaxation phase, ventricular filling, and atrium contraction. The systole consists of two subphases: isovolumetric contraction phase and ventricular ejection. So, step by step, how does the cardiac cycle work? Okay, so over here we have the left side of the heart. The left side of the heart is connected with pulmonary circulation. So let's say it's over here. Okay. The left atrium is separated from the left ventricle by the atrioventricular valve, the mitral valve. Okay. The left ventricle is separated from the aorta by the aortic valve. So after aorta, there are smaller arteries. After the smaller arteries, there are resistance blood vessels and the veins. Okay, so basically this is how the cardiovascular system looks like. Okay, so before I will start to describe the cardiac cycle, you need to get familiarized with the so-called Boyle law. According to the Boyle law, the pressure depends on two factors: the capacity of the capacity of the, let's say, of the chamber, or whatever consists fluids in. So first one is the capacity, and the second factor which influences pressure is volume. So pressure can be changed by two factors: capacity and volume. It doesn't matter whether it is a left ventricle, or whether this is aorta, or other small blood vessels. Blood pressure always depends on those two factors: capacity and blood volume. During the filling phase, the blood flows from the pulmonary circulation to the left atrium, and then through the opened mitral valve to the left ventricle. Because of the filling, the blood volume in the left ventricle increases. Soon after the filling phase, the semi-atrial node pacemaker cells generates the action potential, which then propagates along the cardiomyocytes of the right and left atrium, stimulating the cardiomyocytes of the atria to contract. The left atrium contraction pushes additional blood volume to the left ventricle, increasing blood volume in the left ventricle. Because the blood volume in the left ventricle increases, the pressure increases as well. When the blood pressure in left ventricle becomes greater than the pressure in the left atrium, the mitral valve closes. Okay, so the mitral valve closes, leading to the next phase of cardiac cycle. During this phase, all valves are closed. Okay, so the the atrioventricular valve is closed, as well as the semilunar valve. So the blood volume in the left ventricle cannot change. The only thing that can change is the blood pressure. The action potential which is generated in the pacemaker cells finally reaches the cardiomyocytes on the ventricles of the ventricle and stimulates these cardiomyocytes to contract. Because of that, the contracting cardiomyocytes generate the tension, which increases the pressure in the left ventricle. When the pressure in the left, I don't know what happened, but okay. When the pressure in the left, when the pressure in the left, when the pressure in the left ventricle is greater than the pressure in aorta, the semilunar valve opens, triggering next phase of cardiac cycle, which is called ejection phase. Ejection phase. During the ejection phase, the blood from the left ventricle is ejected to the aorta. Ejection phase lasts as long as the blood pressure in left ventricle is greater than the pressure in aorta. When the blood pressure in the left ventricle becomes smaller than the pressure in aorta, the semilunar valve closes, and the left ventricle is one more time a closed chamber. The semilunar valve is closed, the atrioventricular valve is closed, so there is no possibility to change the blood volume in the left ventricle. The closing of the aortic valve triggers the next phase of cardiac cycle, which is called isovolumetric contraction. Similar to isovolumetric contraction, um, mm, similar to isovolumetric contraction, during isovolumetric relaxation phase, the blood volume stays the same. Only the tension decreases. Because of the cardiomyocyte relaxation, the blood pressure in the left ventricle decreases. So once the blood pressure in the aorta, once the blood pressure in left ventricle becomes slower than the blood pressure in a left atrium, the atrioventricular valve opens and the cycle starts from the beginning. So, as I said before, the cardiac cycle describes the changes of blood volume and blood pressure in the cardiac muscle, which leads to closing and opening of the valves, and that's why the blood volume changes in the heart and cardiovascular system. During the cardiac cycle, there are some very important blood volumes that describe the action of cardiac muscle. The first one, which is one of the most important, is end diastolic volume. But before we'll discuss the end diastolic volume, I would like all of you to focus on this graph. This graph represents the changes of the blood volume and the blood pressure in different parts of cardiovascular system. Let's look over here. So on this graph, the purple line represents the blood pressure in the atrium. Okay, the dark green one, this one, no, you can't see it. This one represents the blood pressure in the left ventricles, whereas the light green represent the changes of blood pressure in aorta. So during the filling phase, the blood pressure in the left ventricle and left atrium is basically it changes only slightly. Then we observe the atrium contraction, which increases the blood pressure both in the left atrium and left ventricle. Once the blood pressure in the left ventricle is greater, so this point, okay, when the blood pressure in the left ventricle is greater than the blood pressure in aorta, we observe ejection phase. Before the ejection phase, there is isovolumetric contraction phase. As you can see on this graph, during the isovolumetric contraction force, the blood volume in the left ventricle, which you can see over here, stays the same. So it doesn't change, but the blood pressure increases drastically from around, let's say, 5 millimeters of mercury up to 80 millimeters of mercury. The 80 millimeters of mercury is so-called afterload. So the pressure generated in the left ventricle must be greater than the afterload to open aortic valve. So when the pressure in the left ventricle is around 80 millimeters of mercury, which is actually the diastolic blood pressure, the aortic valve opens and we observe the ejection phase of the cardiac cycle. During the ejection phase, as you can see on this graph, the blood volume in the left ventricle decreases, as well as the blood pressure. When the blood pressure in left ventricle is lower than the blood pressure in aorta, the aortic valve closes, and next we observe the relaxation, isovolumetric relaxation phase. During one more time, the blood volume in the left ventricle stays the same. Okay. When you look at the graph on the line representing the changes of blood pressure in aorta, you can observe this curve over here, this curve. This curve is called dictronic notch, and it represents the changes of blood pressure after closing of the aortic valve. After closing of the aortic valve, the blood has a tendency to return to the heart, so it hits the aortic valve, and that's why we observe a rapid, short-lasting increase of blood pressure in aorta, which is called dictronic notch. So dictronic notch is an increase of blood pressure in aorta due to blood hitting of aortic valve. Okay. So I would like all of you to copy this graph to your notebooks, and I want you to learn to know how to describe a cardiac cycle based on this graph. Okay. So let's focus on the lower part on this graph. This part represent this part represents the blood volume, and it's not working. Okay, maybe not. Okay, so this part represents the volume changes in the left ventricle during the cardiac cycle. As you can see, there are like different volumes which are marked on this graph. There is EDV, SV, and ESV. This is end diastolic volume, EDV. End diastolic volume is the volume of blood in the left or right ventricle during isovolumetric contraction phase. So after closing of the atrioventricular valve, it's a volume of blood in the left or right ventricle during isovolumetric contraction phase. Typically, end diastolic volume is equal to around 120-135 milliliters. End systolic volume, on the other hand, is the volume of blood is the volume of blood in the left or right ventricle after the ejection phase. So this is the volume of blood which stays in the ventricle, left or right, after the ejection of the blood from the ventricle. We may say that this is the volume of blood in the left or right ventricles during isovolumetric relaxation phase. Typically, end systolic volume is from 60 to 70 milliliters. Okay, the difference between EDV and end systolic volume is called a stroke volume. A stroke volume is a volume of blood that is ejected by the left or right ventricle during ejection phase. As I mentioned, the heart muscle contraction is characterized by afterload, but preload as well. The isovolumetric contraction phase is in fact an isometric phase of contraction. So during isovolumetric contraction phase, the tension is generated, and the tension must be greater than the load, which is afterload. So diastolic blood pressure. When the pressure in the left ventricle is greater than diastolic blood pressure, the tension generated by the cardiomyocytes on the ventricle is greater than the load. The semilunar valve opens, and we observe the isotonic phase of contraction, which is, in case of my heart muscle, ejection phase. During ejection phase, the cardiomyocyte shortens, which allows to eject the blood from the heart. So please remember that afterload is actually the diastolic blood pressure. So the tension which is generated during the isovolumetric contraction phase must increase the blood pressure in the left ventricle above diastolic blood pressure. Only after that, the semilunar valve, the aortic valve, opens, and the ejection phase, which is isotonic phase of contraction, can be observed. Over here you have some definitions. Some of them we have already discussed, but we need to discuss some more, like the ejection fraction. Ejection fraction is the definition of the definition of ejection fraction is related to ejection volume, so the stroke volume, but ejection fraction is presented in percentage. So basically, ejection fraction is the amount of or percentage of blood that is pumped out of the ventricle during the contraction. To calculate ejection fraction, we must divide stroke volume by end diastolic volume and multiply it by 100%. The other very important feature of cardiac cycle is a venous return. Venous return is the volume of blood that returns to the right atrium during 1 minute. In physiological conditions, venous return must be equal to the parameter which is called cardiac output. And cardiac output is the volume of blood that is ejected by the ventricle during 1 minute. In physiological condition, this is from 4 to 8 liters per minute. Cardiac output depends on two factors, heart rate and stroke volume. Because the range of cardiac output is quite is maybe not huge, but it is large, from 4 to 8. It doesn't describe the activity of the heart too precisely. That's why in clinics, instead of cardiac output, the cardiac index is used to describe the activity of the heart muscle. A cardiac index is basically a cardiac output which refers to the body size, so body surface area. So cardiac output is volume. Cardiac index, sorry, is the cardiac output value based on the patient size. So to calculate the cardiac index, we need to know the cardiac output and body surface area, which can be found in a special tables. And now, maybe before I will give you the definition of systolic and diastolic blood pressure, let's go to Frank Starling law. During the skeletal muscle physiology, you perform an experiment during which you examine the effect of the muscle length on the contraction force. On the contraction force. During this experiment, you proved that to develop maximal active force of the contraction, the muscle must be pre-stretched to so-called optimal resting muscle length, in which the myosin and actin filaments overlap each other in a perfect manner, allowing to create the optimal maximal number of cross bridges after stimulation, after the action potential is delivered to the cell membrane of cardiomyocytes. And this relationship between the pre-stretching of cardiac muscle and the active contraction force is described by the Frank Starling law. According to Frank Starling law, the ability of the heart to change its force of contraction and therefore the stroke volume depends on the venous return. So we may say that venous return is the factor which is responsible for pre-stretching of the cardiomyocytes, but in reality, the blood volume which pre-stretches the cardiomyocytes up to optimal muscle resting length is EDV, and diastolic volume, also known as a preload, pre-stretches the cardiomyocytes to optimal muscle length, and after stimulation the cardiomyocytes develop maximal active contraction force. That's why EDV is so important. Decreased EDV means decreased stroke volume. Decreased stroke volume results in decreased cardiac output, and the consequences of that are quite negative. Okay, the Frank Starling law can be presented on the volume pressure loop. This loop, which you can see on the graph, represents the blood volume and blood pressure changes in the left ventricle. This loop, volume pressure loop, is also a great way to present the cardiac cycle. Okay, so let's start with the dots. A, B, C, D. Okay, let's start with the E. But first, let's look on the axis. The x-axis, as you can see over here, is the left ventricle volume in milliliters, whereas the u-axis, represents the ventricular pressure. Let's start with the point A. The point A represents the point during which the mitral valve opens. Okay. And after that, the blood volume in the left ventricle increases. So, point 8 indicates end systolic volume, and from point A, we can observe the filling phase of cardiac cycle. During the filling phase of cardiac cycle, the blood pressure stays exactly the same. It's very low, around 5 millimeters of mercury, but the blood volume in the left ventricle increases. After the filling phase, we observe the contraction of the left atrium, which pushes additional blood volume to the left ventricle. Because of that, because of the atrium contraction and increased blood volume in the left ventricle, the pressure in the left ventricle also slightly increases to, let's say, 10 millimeters of mercury. When the pressure in the left ventricle is greater than the pressure in the left atrium, the mitral valve closes, point B, and the blood volume in the left ventricle at this point is equal to end diastolic volume. So this is EDV. After closing of the mitral valve, there is isovolumetric contraction phase. During isovolumetric contraction phase, as you can see on the graph, the blood volume stays the same. It doesn't change. The only thing that changes is the blood pressure in the left ventricle. It goes up. It increases. Okay. When the blood pressure in the left ventricle is greater than the pressure in aorta, the aortic valve opens, point C, and this starts the ejection phase of cardiac cycle. During the ejection phase of the cardiac cycle, the aortic valve is opened, the mitral valve is closed. Okay. During ejection, the blood volume in the left ventricle decreases, as well as the pressure. You can see that the blood pressure in the left ventricle at which the aortic valve opens is equal to diastolic blood pressure. Okay, diastolic blood pressure, 80 millimeters of mercury. The ejection phase ends by the closing in of the aortic valve due to high blood pressure in aorta. So when the blood pressure in aorta is greater than the blood pressure in left ventricle, the aortic valve closes, and this starts the isovolumetric relaxation phase of cardiac cycle. At this point, the blood volume in the left ventricle is equal to end systolic volume, okay, which stays the same, and the blood pressure in the left ventricles reduces drastically. When the blood pressure in left ventricle is lower than the blood pressure in aorta, the mitral valve opens, and the whole cycle starts from the beginning. I want all of you to memorize this graph, and I want all of you to know how to draw this graph, including the numbers. So you need to know what is the value of end systolic volume and diastolic volume, what is the pressure during which aortic valve opens, closes, and what's the pressure at which the mitral valve opens or open and close. Okay, so the volume pressure loop can look differently when different chemical substances or when different substances act on the heart muscle, or maybe not always the chemical substance must modulate the heart activity, but also changes in the blood volume can also have impact on the volume pressure loop. So let's first start on the impact of preload on the volume pressure loop. The green line represents the volume pressure loop. In case of decreased preload, and the red one represents the volume pressure loop in case of increased preload. So, sorry for a moment, I need to check something. Okay. So, in case of decreased preload, the only thing that change is the volume of blood in the ventricle, which is over here, which is reduced, and because the blood volume in the ventricle is reduced, the blood pressure in the ventricle is also slightly decreased. Okay, and now decreased EDV results in reduced pre-stretching of the cardiomyocytes, and therefore the contraction force of cardiomyocytes is decreased. Okay, the afterload stays the same. So to open the aortic valve, the cardiomyocytes must increase the blood pressure in the left ventricle up to 80 millimeters of mercury. So the isovolumetric contraction phase has exactly the same duration as in normal contrast situation. Because the contraction force is decreased, the ejection phase, which is isotonic contraction phase, is shorter. So less blood is ejected from the left ventricle. The duration of the ejection phase is exactly the same as in case of normal preload, as well as the duration of isovolumetric relaxation phase. So in total, decreased preload results in decreased duration of filling phase, slightly decreased blood pressure in the left ventricle during the filling phase. The isovolumetric contraction phase duration is the same, and because of decreased contraction force due to reduced pre-stretching of the cardiomyocytes, the isotonic phase of the contraction, so ejection phase, is shorter. In case of increased preload, the ventricular filling duration is longer. Okay, because the blood volume in the left ventricle in case of increased preload is greater. That's why the blood pressure in the left ventricle before the isovolumetric contraction phase is also slightly higher. So the line is not flat. This line is not flat. It goes slightly up when the preload is increased. Okay, the preload has no effect on the isovolumetric contraction phase. So during this phase, the blood pressure increases up to diastolic blood pressure. The aortic valve opens. Because of increased pre-stretching of cardiomyocytes, the ejection phase, so isotonic phase of contraction, is prolonged. That's why the volume of blood that is ejected from the ventricle is greater as well. So stroke volume is increased. The aortic valve closes at the same pressure as in control situation, so around 100-110 millimeters of mercury, and the duration of isovolumetric relaxation phase stays the same. Okay, so this was the effect of preload on volume pressure loop. Right now, let's look on the effect of afterload. So the impact of increased diastolic blood pressure on the volume pressure loop and on the activity of heart muscle. Increased afterload can be observed especially during the static exercise. So during an exercise during which the muscles are contract, okay, and the contraction is not followed up by the immediately by the relaxation. In case of afterload, the end diastolic volume always stays the same. So it doesn't matter whether the afterload is increased or decreased, EDV and diastolic volume stays the same. Okay, so let's start with decreased afterload. As I said, end diastolic volume is the same. Okay. When the blood pressure in the left ventricle is greater than the pressure in left atrium, the mitral valve closes, and we observe isovolumetric contraction phase. Because the afterload is lower, so it's not 80 millimeters of mercury like in case of control situation, but it can be reduced up to, let's say, 60. Yeah, let's call it 60 millimeters of mercury. The duration of isovolumetric contraction phase is reduced because the cardiomyocytes must generate the tension generated by the cardiomyocytes of the left ventricle doesn't have to be so high. So it's easier to generate the pressure around 60 millimeters of mercury compared to 80 millimeters of mercury. That's why the isovolumetric contraction phase duration is reduced. Once the blood pressure in the left ventricle is greater than the afterload, in our case 60 millimeters of mercury, we observe the ejection phase. Because the blood pressure in aorta is low, the duration of ejection phase is longer, and the longer the ejection phase, the greater the stroke volume. Okay, because the duration of ejection phase is longer and the stroke volume is greater, the end systolic volume, so the amount of blood in the left or right ventricle, in our case left ventricle, after the ejection phase, is in this case reduced. So end systolic volume is reduced. Because end systolic volume is reduced, the filling phase of cardiac cycle is prolonged. In case of increased afterload, like I said during the static exercise, the blood pressure in the left ventricle during the isovolumetric contraction must increase drastically. So let's say that the diastolic blood pressure is equal to 120 millimeters of mercury. In this case, the blood pressure in left ventricle must be a bit higher. So during the isovolumetric contraction phase, the tension generated the tension generated by the cardiomyocytes must increase the blood pressure above 120 millimeters of mercury, so above afterload. That's why the duration of isovolumetric contraction phase is longer. Okay, once the blood pressure in the left ventricle is greater than the blood pressure in aorta, the aortic valve opens and we observe the ejection phase. Because of the high blood pressure in aorta, the ejection phase is shorter because the blood pressure in left ventricles becomes lower than the blood pressure in aorta quicker than in normal situation. That's why the aortic valve closes faster. Because of the closing of the aortic valve, the ejection phase is shorter. More blood stays in the left ventricle, so the stroke volume is decreased and systolic volume is increased, and diastolic volume stays the same. Because the blood pressure in the left ventricle after the ejection phase is still very high, the relaxation phase, the isovolumetric relaxation phase of the cardiac cycle is longer. So it takes longer to reduce the blood pressure in the left ventricle below the blood pressure in the left atrium. Okay, and finally, the impact of inotropic of the substances that exert inotropic effect, positive or negative. The red line represents the impact of inotropic positive. It represents the inotropic positive effect, whereas the green one, inotropic negative effect. The inotropic positive effects of the red line can be observed in case of let's say, the impact of norepinephrine of cardiomyocytes of the ventricles. Okay, so what is the impact of inotropic positive effect on volume pressure loop? So the contraction force of cardiomyocytes is increased. Okay, so and diastolic volume stays the same. After the closing of mitral valve, we observe the isovolumetric contraction phase, which is the same in inotropic positive, negative, and control situations, because of the afterload, which stays the same in all situations. Because cardiomyocytes activity, so contractility is increased, the isotonic contraction phase of the contraction, the isotonic phase of contraction is longer, which means that more blood is pumped out from the heart during the ejection phase. Okay, because of that, the end systolic volume is reduced. Because the end systolic volume is reduced, the blood pressure in the left ventricle during the isovolumetric contraction phase is lower, and the relaxation phase, because of that, the relaxation phase is a bit shorter compared to the normal or inotropic negative effect. So in total, the chemical substances that have inotropic positive effect prolong the ejection phase of cardiac cycle, Because of that, end systolic volume, the stroke volume is increased and systolic volume is decreased. The duration of isovolumetric relaxation phase is slightly decreased, as well as the blood pressure in the left ventricle during the isovolumetric relaxation phase and at the beginning of the filling phase. In case of the chemical substances that have inotropic negative effect, EDV stays the same, the isovolumetric contraction phase duration is the same. The duration of ejection phase is shorter due to reduced contraction force of the cardiomyocytes, so the isotonic phase of contraction is shorter. Because of that, the stroke volume is reduced. Okay, because the stroke volume is reduced and systolic volume increases. The end systolic volume increases. That's why the duration of isovolumetric relaxation phase is a bit shorter compared to the normal situation. Okay, as well as the blood pressure in the left ventricle during the isovolumetric relaxation phase and the filling phase. The filling phase starts from the higher blood pressure in the left ventricle in case of decreased contraction force of the cardiomyocytes. So basically, that's the effect of afterload, preload, and inotropic agents on the volume pressure loop. Please copy this graph to your notebooks, and I expect you to know how to you are supposed to know how to you are supposed to know how to present the volume pressure loop and the impact of preload, afterload, and contractility on the shape of the loop, including the values of blood pressure and blood volume in the left ventricle. Okay, so right now let's discuss the blood pressure. As we said earlier, the blood pressure, systolic and the blood pressure depends on the two factors according to Boyle law. Depends on the volume and the compliance. The greater the volume, the greater the volume, the greater the pressure, and the lower the volume, the lower the volume, the lower the pressure. During the cardiac cycle, the blood volume and blood pressure not only changes in the heart, but in the cardiovascular system as well. And please let me switch the presentation. I want to show you a graph, which is over here. Okay, so let's start with the systolic blood pressure. A systolic blood pressure is a pressure in the arteries during the ejection phase of cardiac cycle. Okay, so this is the pressure of blood in the arteries during the ejection phase. During the ejection phase, as you can see on this graph, blood is delivered to the arteries from the left ventricle by the aorta. Okay, this increases the blood volume in arteries during the ejection phase, And as we said, the greater the volume, the greater the blood pressure. That's why the systolic blood pressure, the blood pressure depends on the stroke volume and cardiac output. Okay, stroke volume and cardiac output. Diastolic blood pressure, which is the blood pressure in the arteries during the relaxation phase of the cardiac cycle, refers to the situation during which the semi-atrial semilunar valve is closed, aortic valve is closed, so there is no blood flow from the left ventricle to arteries. That's why the blood volume in the arteries cannot increase during the relaxation phase of cardiac cycle. The blood flows from the arteries to the veins through the resistance blood vessel. So the greater the blood volume in the arteries during the relaxation phase of the cardiac cycle, the greater the diastolic blood pressure. The lower the blood pressure in the arteries during the relaxation phase of cardiac cycle, the lower the diastolic blood pressure. So we may say that the blood volume in the arteries depends on the blood flow velocity from arteries to veins. Okay, so the faster the blood flow, then the lower the blood volume in arteries and the lower the blood pressure, diastolic blood pressure. The greater the one more time. The greater the blood flow through the arteries to the veins, the smaller the blood volume in the arteries, and that's why diastolic blood pressure is low. Okay, and the other way around. The smaller the blood flow, the smaller the velocity of blood flow from arteries to veins through the resistance blood vessels, the greater the blood volume in the arteries and the greater the blood pressure. Okay, so we may say that the diastolic blood pressure directly depends on the flow through the resistance blood vessels, and this velocity of the blood flow depends basically on the peripheral resistance, which, as you can see, let's switch. As you can see on this graph, the resistance in the blood vessels depends on the blood viscosity, blood vessel length, and the radius of the blood vessels. So when the blood vessel radius, the resistance the resistance of the blood vessels is high, the radius is when the blood vessel resistance is high, the blood can flow faster from the arteries to veins. So the speed, the velocity of the blood flow is increases, and this decreases the blood volume, and that's why the diastolic blood pressure is lower. In case of a small blood vessel reduce, so for example, during the during the static exercise, the contracting muscles decrease. The contracting muscles, the contracted muscle press the blood vessels, decreasing the blood vessel radius. So the blood vessel radius is small. This increases the blood vascular resistance. That's why the velocity of blood flow is reduced, and this causes this leads to increased blood volume in the arteries, and that's why the diastolic blood pressure is increased. When the diastolic blood pressure is increased, the afterload is increased as well, and that's why the heart muscle must work harder. The duration of isovolumetric contraction phase must be prolonged to generate the proper pressure in the left ventricle. So right now you can see that systolic blood pressure depends on the stroke volume or cardiac output, whereas diastolic blood pressure depends on the radius of the vascular resistance blood vessels, which depends on the blood vessel radius, has impact on velocity of the blood flow and the blood volume in the arteries. Okay, so the vascular resistance and the blood vessel radius can be regulated by a sympathetic nervous system. A sympathetic nervous system innervates all vessels except from capillaries, precapillary sphincters. The innervation of the small arteries and arterioles allow to increase vascular resistance. So when the sympathetic nervous system activity is increased, we may expect increased vascular resistance. But please remember that the vascular resistance and therefore blood pressure regulation depends on the factor which increases the activity of sympathetic nervous system. In case of large veins, the innervation of the large veins by sympathetic nervous system regulate the venous return. So, for example, the increased sympathetic activity, the increased activity of the sympathetic nervous system may lead to the vasoconstriction of the veins, and therefore regulating the venous return. The other factor which is very important for the cardiovascular system is mean arterial pressure. Mean arterial pressure represents the blood pressure in the arteries. It depends on the systolic and it can be calculated by the using the systolic and diastolic blood pressure. So mean arterial pressure is equal to diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. As you can see on this graph, mean arterial pressure depends on cardiac output and total peripheral resistance, which depends on the blood viscosity, the length of the blood vessels, and the blood vessel radius. Central venous pressure is in most of the cases equal to 0 millimeters of mercury. That's why when we calculate mean arterial pressure, we do not take under consideration central venous pressure. Okay, mean arterial pressure is very important parameter because it represents the tissue perfusion. So it represents the amount of oxygen which is delivered to the tissues. In case of reduced cardiac output and or total peripheral resistance, the mean arterial pressure is decreased, and therefore the tissue perfusion is reduced as well, which means that the amount of oxygen delivered to the tissue is too small. Okay. And basically, I think that we may finish right now. During the tutorials, sorry that this is in Polish, I don't know why. During the tutorials, at the third tutorials, I think that during the third tutorial, we are going to discuss the neural control of cardiovascular system. We are going to discuss the central command mechanism as well as the reflexes which are responsible for the regulation of cardiovascular system, including baroreceptor reflex, baroreceptor reflex, and we will discuss some of other baroreceptors like mechanoreceptors type A and type B, including Bainbridge reflex. And yeah, that's basically it. I hope that you enjoyed the lecture and it's going to be a good material for you, a good source of knowledge for the tutorials. If you have any questions, please contact me on the Teams. I'm always happy to answer your questions. And I will see you during the tutorials, I think in 2 weeks. I think so. I will in the next days I'm going to send you the list of the issues which are supposed to prepare for the tutorials. Okay, so do you have any questions?